Well, let's go ahead and get started. I wanted to welcome everyone to tonight's webinar. I am your moderator and host, Dr. Lauren Levine. Welcome, everyone. As always, whenever Dr. Kosinski speaks, we have just a massive turnout. We always get over 1,000 people. No different tonight. We're just north of 1,100 that are registered. As always, I start off making sure that everyone is hopefully staying healthy and safe. I'm only going to speak for a couple of minutes. I want to make sure that Dr. Kosinski can speak for as long as he needs. He wants to take as many questions as possible. I want to give everyone fair warning, as I always do. With this many people on the webinar, it is extremely rare that we get to all the questions. I see them as they come in. I will try to combine as many as possible and try to get to as many as we possibly can. If we did not get to your individual question, I apologize. We want to be respectful of Dr. Kosinski's time and your time. We always we'll end the webinar 90 minutes after it starts. So, but we'll do our best to get them as much as we can. For those of you who maybe are new to GoToWebinar, you have a little control panel on your screen, and you just type in your questions as you think about them. We don't obviously do verbal questions with this many people on, but just type it in, and that's when I said I'll try to get to as many as possible. In the next couple of days, look for a few things. This webinar is being recorded. You will get a copy of that recording that you can download and review it at your convenience. So don't worry if you can't make it to the end, not a big deal. During the webinar, Dr. Kosinski is going to be demonstrating a number of products which he uses, which are exclusive to GoldenDent. I've had the pleasure of doing webinars with GoldenDent for a few years now. These webinars definitely would not happen without their sponsorship, and I thank them for that. You know, they bring in the speaker, they help develop the content and marketing, and they handle the CE and the recording and all that stuff. So thanks to them. Speaking about CE, I get emails after the webinar constantly. I'm going to try to mention it a number of times this evening. If you are on the webinar and you stay on the webinar, you're going to get the CE form. There is nothing you need to do afterwards when you log out. There's no quiz, there's no test, there's no verification. It'll get sent to you. You have to stay on for, I don't know exactly how much of the webinar. I know AGD PACE has certain requirements. I think it's like 80%. But like I said, if you're here for all of it, then you'll be sent that CE form automatically. We do have, as I said, over 1,100 people registered. So please be patient about that. It can oftentimes take a couple of weeks. I send a list to GoldenDent. They review it. They get the CE form sent out. So watch your inbox within the next couple of weeks as well. With that out of the way, I am so thrilled to have Tim Kosinski back. Any of you that have not listened to Tim in the past are in for a real treat, and those of you who have heard him in the past are in for a real treat. Tim is not one of those presenters that you see the same slides regurgitated for decades. It's new content. It's always good stuff. For those of you who don't know Tim, he's an affiliated adjunct clinical professor at the University of Detroit Mercy School of Dentistry. He serves on the editorial review board of Reality, which is the aesthetic dentistry magazine. He's the past editor of the Michigan Academy of General Dentistry. He's currently the editor of the AGD journals, and he was recently named editor of Implants Today. He's past president of the Michigan Academy of General Dentistry. He got his DDS from the University of Detroit Mercy Dental School. He got a mastership in biochemistry from Wayne State University School of Medicine. He's a diplomat of the American Board of Oral Implantology and Implant Dentistry, the ICOI, the American Society of Osteointegration. He's a fellow of the American Academy of Implant Dentistry and received his mastership in the Academy of General Dentistry. He's received, if you're out there, if you've been to trade shows, if you've been to lectures, you obviously know who Tim is. He's received so many honors, fellowship in the American and International College of Dentists and the Academy of Dentistry International. 3 or 4 years ago, he received the Academy of Dentistry International's Humanitarian Award in recognition for significant contributions to the enhancement of the quality of life and the human condition. He's a member of OKU, the Pierre Fauchard Academy. He was University of Detroit School of Dentistry Alumni Association's Alumnus of the Year in 2019, 2014, 2020, which last year he received the Academy of General Dentistry's Lifelong Learning and Service Recognition. If you think you've placed more implants than him, you may be wrong because he's placed over 15,000 implants. He's published over 200 articles on surgical and prosthetic phases of implant dentistry. He's a contributor to textbooks like Principles and Practices of Implant Dentistry and Dental Implantation and Technology. If you've ever seen the Noble Care of Noble Vision, then he's on it. He was featured on it, and he lectures extensively all across the world. So, Tim, so thrilled to have you back, and we're looking forward to the presentation this evening.
Thanks, Lauren. You always make me chuckle. Good evening, everybody. Well, I guess we'll just get started. We'll try to respect everybody's time, and this is a pretty exciting topic that's becoming very, very popular as implant dentistry's become more popular, Lauren. More and more general dentists are becoming proficient and efficient in implant dentistry, and grafting, extraction techniques and grafting is an integral part of what we do in implant dentistry today, creating the foundation, so to speak, for proper implant placement. You know, I like to say that the days of just placing implants where there was available bone and then making teeth and having the patient have to accept it are long gone. Our patients really are demanding, for lack of a better word, emergence profile, smile design. So ideal placement of our dental implants is critical. And with our newest technology, CBCT analysis and scanning devices and milling, we're able to diagnose and plan our cases much more precisely than ever before. But again, grafting is a very, very important part of implant dentistry, whether or not we want to immediately place our implants, meaning if we're going to take a tooth out and place an implant in an extraction site immediately, grafting is very important. And I explain that to my patients all the time. We're going to take a tooth out. We're going to create a socket, Lauren, that is the shape of an egg. And I think you understand that. Everybody here just visualize the shape of an egg. But our implant is round, and we have a series of drills to make our osteotomy site. But we will fill that socket with some type of grafting material, and we're going to specifically talk about two tonight to fill in the void, so to speak, almost like caulking. And our patients respond to that very well. Sometimes we're not able to place our implant immediately. If we have active infection in a site, then we may want to graft the site first and then come back and place an implant after that graft material has had a chance to integrate within the body and form natural bone. So let's get into it. So as Lauren said, I practice outside of Detroit, and I'm very proud to be a part of my university. A lot of the things that we show are on my education website, which is drkosinski.com, or on the GoldenDent website. We have many millions of YouTube views with our clinical cases. So videos and demonstrations that we have are certainly available either on my website or on the GoldenDent website, and fairly easy, accessible to you. So, you know, our objectives, as we talked about, I'm not going to spend a lot of time on this. We're really going to do clinical stuff today. We're going to review surgical techniques. We're going to show two different types of grafting materials. There's 100 ways of doing what we're going to demonstrate today, Lauren. And I'm a big believer in simplicity and financial integrity. So I'm going to show you the materials that I use. I like to say in my lectures that you know, I can grow bone 100% of the time, and that sounds like a very bold or bold statement to make, but it's really true. And so I'm just going to demonstrate some simple techniques that I use when we have all walls intact, all four walls intact, and even when we have the facial wall missing. I'll call that a three-wall defect. But certainly with the materials that we're using, the membranes that we're using, you're going to be able to predictably provide the service to your patients. But this is going to mean that we have to evaluate the reflections that we make. The flap design is very, very important, and suturing is very important in the overall healing of our implant sites. And we'll talk about immediate implant placement. I'm going to show you some recent cases that we just did last week, and things that you're going to see in your practice just about every day. We know when we have a tooth in the posterior maxilla, those that three-rooted tooth has large roots, and those roots are supporting the sinus floor. I'd like to use the analogy, if you heard me say this before, is a sinus is simply an air cavity that God created to keep our skull light and also warm the air. But a tooth root acts like a tent pole holding up a circus tent. And we all know that when a tooth is lost, bone is going to shrink. In the maxilla, bone shrinks up and in. But also, when the tent pole in that area is removed, what happens to the circus tent? Well, it simply collapses. And that's what we oftentimes see in our practices. I know in our programs and our teaching programs, our doctors are concerned about two basic areas of the mouth: the posterior maxilla, because they're worried about the sinus, and they're worried about the posterior mandible, and they're worried about the mandibular nerve. And obviously, we never want to hurt a patient. So I think it's imperative that you communicate with your patients very clearly. If we're going to take a tooth out, it's important that we graft that site. Why? Because physiologically, bone is going to shrink. It's going to shrink up and in the upper jaw, down and in the lower jaw. And in the posterior maxilla, that sinus can collapse. So kind of reinforce your little speech to your patients on why grafting is so critical in this area. If we remove a tooth and we do not graft the site, well, then physiologically bone is going to shrink. How much? I have no idea. But again, if the bone shrinks to a certain level and we're not able to place an implant, say in 4 months, well, then it becomes a much more invasive surgical procedure and a much more expensive procedure for our patients to create adequate bone, meaning a Caldwell lock, sinus elevation procedures, sinus fill procedures, and much more traumatic to the patient. So for a very minimal cost, we're able to maintain a certain amount of physiologic bone in an extraction site. So here we have a tooth. I probably do more implants on teeth that have root canals and posts than anything else, but we have a fractured root. Our endodontist determined that this tooth is non-salvageable. And so we talked to the patient about extracting the tooth. Now, how do you remove a tooth in your practice today? You can actually see the fistula that was created from the root fracture. Patient is uncomfortable. And I challenge you, how are you removing teeth in your practice today? Is this a difficult tooth to remove? Is it a simple tooth to remove? Well, everybody has different experiences. Some of you may want to remove this crown first. Now, there's different techniques to remove a crown. I think most of us would probably take some type of burr and section the facial aspect through the occlusal onto the palatal aspect of this tooth and somehow separate the crown. We would then, some of us would section the roots, mesial buccal, distal buccal, palatal, and remove the tooth that way. Some of us would luxate, different protocol. However, it's very, very important that we maintain the integrity of the root structure and that we don't fracture root tips. I see so many areas of the mouth where root tips were left. Why? Because taking teeth out is challenging. It's hard. It's hard work. It can be frustrating. And oftentimes we just give up. So I'm going to show you very briefly a technique that I use to remove teeth just about every day. It's an instrument that I would not practice without. So again, we determined that this tooth is not treatable and we're going to remove it. So I will simply take a periotome. These are GoldenDent periotomes. These are really nice instruments. They're plasma vapor deposit coated. They're very strong, they're scratch resistant, and a very, very high quality instrument. And at the end of the program, when you have a chance to talk to Kurt, with GoldenDent. I'm assuming that they have some specials. We have created a grafting kit, and some of our extraction instruments are certainly available to you, things that I use, again, in my practice every day. So basically, I'm just going around the tooth. Now, some of us may say, well, you know, you're just trying to break the periodontal ligament, and that's not really what I'm doing here. To some degree, I am, but I'm really making sure that I have profound anesthesia in this area, because I'm just infiltrating around this tooth, both facially and palatally. So taking my periotome and just making sure that the patient only feels pressure, no discomfort. And then I'm going to use something, and I hope most of you are aware of this product. If not, please take some time with Kurt with GoldenDent, because this is a series of 4 instruments that I honestly would not practice without. They're called the physics forcep. I wish they weren't called forceps, because they really don't act as forceps. They act more like luxators. But it's a series of 4 instruments: an upper right, upper anterior, upper left, and a lower universal instrument. It consists of 2 components, a beak and a bumper. The beak is actually the shovel-shaped edge, which is the working end of the instrument. That will engage, in this situation, the palatal aspect of the root, 1 to 3 millimeters subgingival. The bumper, which is a little silicone sleeve, is placed as high up the vestibule as possible, and simply serves as a fulcrum, or a center of rotation. It is not the working end of the instrument. It is not holding the facial plate of bone whatsoever. It's simply working as a center of rotation for this uniquely shaped rounded bevel of the instrument. So the serrated beak will engage the palatal aspect of the tooth, the bumper guard, and the bumper simply acts as a fulcrum. And you can see I'm actually placing the beak 1 to 3 millimeters subgingival onto the root structure. Now, if you find that this instrument is sliding off of that root structure, then what I would do is I would take say a 557 surgical burr, and I would flatten that root structure. I'm not removing bone, simply flattening the root structure so that I have a purchase point for that beak placement. I'm placing the bumper as high up the vestibule as possible, and without squeezing the handles. I am not squeezing the handles. I am simply rotating my wrists, creating tension on the palatal aspect of this root, rotating the wrist towards the corner of the eye. This tension is going to create a physiologic response. It's going to create an enzymatic release that is going to break down the periodontal ligament. Now, doctors, what's holding this tooth in place? The periodontal ligament. If the periodontal ligament is melted away, this tooth will luxate or rotate up and out of the socket following that arc of rotation of the instrument. It's a very specific instrument, and this may take about a minute. Now, I know a minute is a long time for a dentist, but it's certainly something that without any forearm, bicep, shoulder forces whatsoever, our patients are not responding to the incredible force that we will often put on a tooth with conventional forceps, and the process becomes what I like to refer to as atraumatic, meaning it's going to be atraumatic to the patient. Oftentimes the patient will look at you and go, "You took the tooth out, you're kidding." Atraumatic to your body. As I'm getting older, saving your body has become very, very important. Your back, your eyes, your ears, and obviously saving as much of the hard tissue or bone as possible. So you can see in a matter of about a minute, this tooth luxated up and out of the socket. Now, the instrument is not intended to remove the tooth in total. Rather, it's intended to raise or elevate this tooth up and out of the socket. And I will then take what we call a tooth delivery instrument to actually remove the tooth totally once the periodontal ligament is destroyed. Again, I'm not squeezing the instrument whatsoever. It's simply a wrist rotation, and you can see the tension that I'm creating on the palatal aspect is being done by one finger, simply one finger. So this tooth delivery instrument is used, a bird beak forcep that is part of our extraction kit with the GoldenDent system. And I can simply remove this tooth in a matter of minutes without cutting the crown off or sectioning the roots. Now, at this juncture, you can see the divergence of the root. This is not an easy tooth to take out, any stretch of the imagination, especially a root canal treated tooth, but we're able to do it quite efficiently with this instrument. We have very divergent roots here. And Lauren, you always tease me, but I always like to show you new cases, so I hope you appreciate this. But you can see the divergence and the root canal treatment of this tooth. Now, at this juncture, I have 3 sockets. And we're going to want to graft these sockets for future work. A maxillary molar teeth, normally I will not immediately place an implant because I really can't put the implant in an ideal position. Where would you want to put it? The mesial facial root, the distal facial root, or the palatal? Well, the palatal root's the longest. You would think, well, maybe that's where I want to put it. But then the final restoration, the final crown, final prosthesis is going to be too far lingual, and the patients are going to respond to that. I really want to place the implant ideally right in the center. So in this situation, I normally don't like to place an immediate implant. Rather, I will graft and I'll give it 3 to 4 months to heal and then come back and ideally place my implant. The grafting procedure is critical in this situation, again, as I mentioned in the beginning of our program, to keep that sinus floor from falling, and also trying to minimize the bone loss that you would expect physiologically, both coronally and facially. So take a radiograph, make sure that all the roots are removed, the tooth structure is totally removed, and we're going to curette. We need to eliminate all the granulation tissue. And again, the grafting kit that we created with GoldenDent is a really nice, inexpensive, very cost-effective kit that I use. You must have sharp instruments to be able to curette any granulation tissue from the site. And purple blood is bad. Okay, purple blood is unhealthy blood. Red blood is fine. Let's demonstrate one of the 2 products that I want to show you today, and it's called the Osteogen plug. This is from Implant, and it is sold by GoldenDent. It's a bioactive calcium apatite material in a bovine Achilles tendon matrix. And basically what it does is it mimics the organic and inorganic component of physiologic bone. The bovine Achilles tendon matrix is simply a collagen carrier. This is not a collagen plug. This is a very, very specific material that I will demonstrate that I've had tremendous luck. I've published a lot on it. I've lectured all around the country on it. And in a very short amount of time, this material will be converted to natural bone. The bovine Achilles tendon matrix will act as a scaffold for keratinized tissue to grow over the top of it. For those of you who have taken grafting programs before, we know that with our Allograft material, which is the second material that we'll talk about from GoldenDent, Allograft is human bone from another site, from a cadaver. And when we're using an allograft material, we must protect that allograft from invagination of epithelium. Epithelium grows about 10 times faster than bone, and we know that a socket will integrate from the apex towards the crest. Epithelium will go from the crest towards the apex. Who wins that race? Always the epithelium. So it's imperative when we're using an allograft material that we protect that graft using some type of membrane that we'll discuss in a few moments. But we don't need a membrane with this particular product. It's very, very specific. And here I've taken this plug, and Kurt can talk about his specials with it. And basically I cut it with a pair of scissors to kind of mimic the shape of the root that I removed. And again, this makes socket preservation very easy and affordable. It's I think a $50 material, where our allograft material is about $110 or more. per cc. And it's very specific, and we've had tremendous successes with it. So the benefits of this, it's a graft and collagen combination. It fulfills two primary purposes of a membrane for socket preservation. It has the graft material, which is a synthetic. We're not using cow, pig, horse, or human materials. It's calcium apatite made in a laboratory. And as I mentioned, it restricts migration of connective tissue through both a physical and a chemical barrier. And what we'll do is we'll place this graft material, we will place it firmly into the socket. We're not condensing it necessarily like amalgam, but we're condensing it firmly into the socket to the height of the epithelium. So the epithelium now has a choice. It can go into the graft material or go over the top, and it's always going to follow the path of least resistance. So after curetting, I've taken my pre-cut, shaped osteogen plug material, and I'm simply placing it, condensing it into my 3 sockets. We want to condense this material firmly. It's not amalgam, but firmly into the socket to the height of the epithelium. Now, we mentioned earlier that suturing is very, very important. And some of you may have heard my my webinars in the past or seen my lectures in the past. And I'm a big advocate of this suturing technique. Many of us, most of us, I would assume, would suture from facial to palatal in this situation. And oftentimes when we're doing it that way, because we're using a reverse cutting needle, we will engage the graft material, or if we had a membrane in this situation, the membrane. Now, and that could create problems in the future. So my suturing techniques with our reverse cutting needle is I will go from the socket site, the crestal aspect, towards the facial. And because this is only cuts on one end, the reverse cutting needle is going to slide over the top of my membrane or graft material. I will then simply reverse the needle and go onto the palatal. My favorite suture material is the PGA, polyglycolic acid synthetic material. It's braided, it resorbs to water, and will last for about 28 days, although I like to see my patients in a week to 10 days just to evaluate the healing site. Remember that epithelium grows about 0.5 millimeter a day. So I do not need primary closure with these situations, but be realistic, knowing that if we have a 4 or 5 millimeter open wound, it may take 8 to 10 days for that area to cover over with epithelium completely. Other suture materials are silk, which I don't use. Plain or chromic gut are inexpensive, but again, as a dentist, we know we all have our favorites, and the PGA from GoldenDent are my favorite. And this is a nice suturing book. You can get this from Salvin Dental. I think it's $100. Don't go on Amazon. They charge like $1,000 for it or something ridiculous. But Salvin does sell this book in different suturing techniques. And again, my favorite material is the GoldenDent suture, the PGA, polyglycolic acid material. So as I said, I'm then reversing my my needle from the crest to the palatal aspect, and I'm simply doing an interrupted suture. 2 forward, 2 forward, 1 back. We'll keep that knot in place as long as I need it to. I do not expect primary closure here. As a matter of fact, I don't want primary closure here. And again, a whole nother lecture is the importance of attached gingiva on the facial aspect of my implant. We know we have 2 types of tissue intraorally. We have our attached epithelium, and we have mucosal tissue. We can never have mucosal tissue on the facial aspect of our implant. So if I intended to get primary closure here, the only place I could get it from is by pulling that facial tissue towards the palatal, which means my mucosa would end up being on the facial aspect of that site, which I don't want. So I'm simply adding a couple interrupted sutures to this site, and we're getting our closure very efficiently. And this, in essence, will hold that material in place and allow the epithelium to migrate on top of the bovine Achilles tendon matrix. I will see this patient in a week to 10 days to remove the sutures. These sutures do not accumulate plaque. They are braided, they're very easy to tie, and they resorb to water, which is a really nice attribute of this particular suture. Immediately post-operatively, I take a radiograph, and you can see that it's radiolucent. And over time, what's nice about this material is we can objectively take radiographs over time and determine how integration is progressing. I want you to clearly remember, though, that integration is going to occur from the apex towards the crest. So in 3 months, say I would expect more radial opacity at the apical portion of this defect than I would at the coronal portion. However, my initial stability with my implant occurs at the apical 2 millimeters, and therefore I can place my implant and allow this graft to continue to integrate over the following months as the implant also integrates. So let's look at another case where we have a tooth that's fractured vertically, obviously needs to come out. I think you understand the principles of extraction. Atraumatically, we're going to correct the site, eliminate granulation tissue, purple blood. And here again, I'm using my osteogen calcium apatite plug, placing it very slowly into the socket site, condensing it firmly to the level of the epithelium. I then sutured it into place with simple interrupted sutures. And immediately following graft placement, you can see the radial opacity, but objectively look at what happened 4 months post-operatively. Can you see the difference apically? Maybe the apical half of this socket. You can see we're definitely getting a changeover. So in this short amount of time, I feel very comfortable placing a dental implant. Here we're going to do a flapless procedure where we're coring out the soft tissue. And to illustrate, I will oftentimes biopsy this site. I will take a trephine and do a core sample of the grafted site. And the slide on the right, we're not going to go to a lot of histology. I don't want to bore you with that today, but you can see the magenta color. The magenta color is natural bone. The purplish or violet color is our particulate calcium apatite that has not been removed and replaced with natural bone. But you can see we definitely have a large amount of natural bone formation in that grafted site. And that was a big defect, right? We all agree with that. So I go through my implant procedure, small burr, larger burr, and I'm able to place an implant and actually torque it in a grafted site after 4 months to 45 Newton centimeters. That's a tremendous amount of initial stability. I put a cover screw and I'm going to let this implant heal for another 4 months. Our patients are very responsive to this and we get tremendous results. After 4 months, we put our impression, we uncover the implant, we put our impression post, we make our impression, and the laboratory in this situation fabricated a nice screw retained implant zirconia crown, and we're able to create form and function for our patients quite predictably. Doctors, you are capable of doing these cases routinely in your practice. So for those of you who are beginning your careers in implant dentistry, I challenge you to get as much education as possible, work with a fine company like GoldenDent, get the right products, and become very proficient and efficient in your abilities. So if we graft, why is it important to graft? If we graft at the time of extraction, we can prevent or minimize bone loss. We can support the soft tissue architecture to some degree. We can prevent periodontal pathology, and we predictably can provide adequate site for implants in 3 to 4 months, routinely, doctors. However, if we're not going to graft, We can get soft tissue infiltration. I said epithelium grows 10 times faster than bone. It's going to grow into that socket. We can lose height and width of the ridge. And the literature will say we get 30 to 60% bone loss in a 3-year period, which means that the patient may need a more invasive, more expensive graft prior to implant placement in the future. Now, the question that you should all have at this juncture, halfway through our lecture, is, well, my insurance doesn't pay for grafting, my patients won't pay for it. Well, doctors, I think you need to educate and instruct them on the importance of this product or this material or graft, the procedure in a particular site. And take a photo of the list, the 4 things that I mentioned without grafting. You may not be able to have an implant, Mr. or Mrs. Patient, if we don't graft this site and prepare the site for future use. Why do socket grafting failures? Well, I hear that all the time. It's not predictable. I want you to have predictability. You can do the same dentistry that I do every day in your practice. Poor case selection, unhealthy patients, the wound opens too quickly. If you're placing a membrane with allograft, that membrane must be intact for at least 6 weeks. If it's removed or lost before that time, the case becomes unpredictable. Not decontaminating the site properly, and your reflection and your suturing techniques are very, very important. All skeletal bone demonstrate volume stability over time, except what? Our alveolar bone that we have to work with. Why is that? Because the dental alveolus is very labile in the absence of loading. Doctors, if you don't load a site, if you remove a tooth and don't load a site, you have to expect bone loss. How much? I don't know. It's going to differ in different patients. But again, grafting is a very, very important foundation for future implant work. Bone grafting, as I demonstrated, is possible because bone tissue, unlike any other tissue, has the ability to regenerate completely if provided the space into which to grow. As native bone grows, it will generally replace the graft material completely, resulting in a fully integrated region of new bone. And the biologic mechanisms are called osteoconduction, induction, and osteogenesis, which you can Google search it. Okay, we need to know the different types of grafting materials, and I demonstrated the calcium apatite, which is a synthetic material. And let's talk about allograft a little bit, and then we'll do a little comparison. The Goldos particulate graft is a very high quality material, and I'm sure Kurt at the end of the program will have some specials. You should try it. Again, any savings that you can have with a high quality product that is predictable is better for you financially, and better for your patients in that you can reasonably charge this product out and expect an excellent result. Membranes, I'm gonna recommend 2 membranes to you. They're both resorbable, and both can be purchased through GoldenDent, the Epiguide material and the collagen material. Epiguide is a synthetic material, polylactic acid construction. It lasts a long time and easily to handle. And Kurt can go into more detail. It resorbs in 6 to 12 months. I only need the membrane to last for 6 weeks in my situations. There's a lot of grafting materials out there, doctors. They're all over the place. I'm only going to teach today what I use in my practice. We do a lot of implants, a lot of dentistry. You're going to use an allograft material, which can be mineralized or demineralized from GoldenDent. And the other material is, we've already demonstrated, is the osteogen calcium apatite material. You know, this is a great product too. I wanted to bring it up on oral care. As far as rinsing, and obviously with the advent of COVID and our concerns of our patients for not only for their health but for our staff's health, Kurt can discuss this a little bit more detail at the end of the program with some specials. But This IO-Rinse material is, I think, better than chlorhexidine, and does not cause microbial resistance like chlorhexidine, and is 33 times stronger than the iodine rinses that we're using, and it's very cost effective. So you may want to look at this as far as not forgetting about COVID and transmission. And the research is my dear friend Gordon Christensen evaluated it and evaluated very, very highly. So you may want to look into this as a pre-surgical rinse for your patients, especially in the advent of COVID. Let's get back to some clinical cases. We'll do a maxillary molar. This is an interesting case. Again, we're going to compare the osteogen plug to conventional grafting with the allograft material. Both of these teeth need to come out. They've been deemed non-restorable. So what procedure we're going to use? We're going to remove the teeth. I like the physics forcep, whatever technique you want to use. You can see the slide on the left, the tooth was fractured. We're removing the tooth in total. We're going to remove the granulation. So curette, 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 curette. In a conventional allograft technique, remember, we must use a membrane to protect the allograft from invagination of epithelium. So I have to reflect the tissue. I have to reflect it both facially and palatal. Now, doctors, I know we can be lazy as general practitioners, and oftentimes we understand the concept of placing a membrane, but we don't understand the concept of reflection. And so we need to remove the tissue from the bone so that we can clearly see any defect. And our membrane must be passively placed at least 2 millimeters beyond any defect. That membrane must be maintained intact for at least 6 weeks. So the procedure in grafting with an allograft and a membrane is rather complicated, but you can't take shortcuts if you want predictable results. Now with the osteogen plug, we're taking it, we cut it, we're packing it into the site. With the conventional grafting techniques, I'm taking my membrane and passively placing it beyond any defect on the facial aspect. You can see I'm not holding it, I'm not forcing it, I'm not pushing it. That membrane is going to be passively placed. Our osteogen plug does not require a membrane. With the conventional grafting, we must protect the allograft from invagination of epithelium. I'm still going to suture over the top of each. I do not care about primary closure because epithelium will simply grow over the top of that over a period of time. So immediately following graft placement, the results are nearly identical, right? We see radial opacity in both situations. 1 week post-op, you can see how the epithelium is starting to cover over the top of the osteogen graft material, and the epithelium is slowly covering over the membrane that was passively placed that is going to be maintained for a period of time. Here, 1 month, the tissue is starting to heal very, very precisely. And 4 months, you can see the definite change objectively, radiographically, in the quality of the hard tissue that we have developed. Implants are placed. And again, with the osteogen plug, I like to do a lot of histology in that site, and you can see the magenta color is new bone formation, which is very impressive. Let's look at cost. An osteogen plug is, we're going to talk averages here, $50. A vicryl suture, $12 to $16. You must know your overhead in your practice, and let's just throw a number out as say your overhead, your staff, your lights, your electricity, your cable bill, salaries is $400 an hour. Well, it's a procedure, and so that breaks down to $67 in a 10-minute increment. That's how we calculate our financials in our practice. This does not include the extraction. You're billing that out separately. but I'm talking about the graft procedure itself is a 20-minute procedure. Once the tooth is removed, we curette, we plug the osteogen plug into the socket, and we suture. So the total cost with overhead is about $200. Let's say you're charging $630. My profit on that is about $430. With conventional grafting, Allograft 1cc could be $110, although that price is kind of creeping up a little bit, all the way up to $160 for a cc. Membrane, you must have a membrane when we're using Allograft, is another $110. Microsuture is the same. Our overhead is the same, but it takes me more time because I have to reflect that tissue. I have to understand the concept of flapping. It's going to take me longer time to do this procedure. I'm charging a little bit more because I'm placing a membrane, but our net profit is significantly less. So using an osteogen plug, if it really works, and I try to demonstrate to you histologically that it does work, you're going to increase your profit margin by 42%. You're going to do an atraumatic extraction. Your patients are going to look at you and say, wow, I can't believe you took that tooth out so easily. You're going to explain, you're going to communicate to them the importance of grafting in that it's going to minimize or reduce future bone loss, especially in the posterior maxilla. We're worried about the sinus collapsing, and the posterior mandible, we're worried about the nerve, and hopefully will prevent the necessity for a more invasive, expensive grafting procedure in the future to build bone up. You must prepare your site for a dental implant. So explain this to the patient, how important this is. So, I really believe that everyone can immediately implement this type of graft procedure into your practice. It's affordable. You don't need a membrane. It is a graft. It's not a collagen plug. I get very, very predictable clinical results, and it's simple to use. So let's go on. Let's show some more clinical cases for a few more minutes, Lauren, if that's okay, and then we'll get right into the questions. Mandibular molar. Again, a tooth that's deemed non-restorable, horizontally fractured root, infection, things that you're seeing in your practice every single day. Periotome to make sure I achieved anesthesia. And here I'm using the GoldenDent forcep to more conventionally remove this tooth. I'm going to engage the beaks into the furcation area. And a technique that Dr. Golden taught me, I'm going to rotate lingually, and I'm going to hold for 10 seconds. 10 seconds is a long time for a dentist, but hold for 10 seconds. What are we doing by doing that? We're creating tension, which is going to result in a physiologic reaction. Enzyme is going to be released, which is going to break down the periodontal ligament. I then will take my forcep and rotate facially and hold again, and do that several times, and I'm able to remove this tooth relatively atraumatically to the doctor, the patient, and to the available hard tissue. Take a radiograph, make sure that the tooth is removed in total, and doctors, please curette, 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 curette. Remove that granulation tissue, yuck. And here I'm going to make a reflection, and I'm going to refer to this as an envelope reflection. I'm not going to make a vertical incision whatsoever here. I'm going to go around the tooth, and I want to stay away from incising into mucosa. When you incise in the mucosa, the patients are going to be uncomfortable because you are going to release histamine and prostaglandins, and the patients are sore. If you eliminate reflecting or cutting into mucosal tissue, our patients really do not experience a lot of discomfort postoperatively, and will simply take Advil. So I'm making what we call an envelope reflection, and I have to see the defect. We have a facial defect here. I did not create it. The infection created that defect. I'm going to take my osteogen plug and simply place it into the socket to the crest of the epithelium. I'm packing it firmly, again, to the crest of the epithelium, and I'm going to suture it maintaining a band of attached gingiva on the facial aspect of this defect. 1 week post-op, you can see I do not have complete closure. I will explain to the patient that epithelium grows 0.5 millimeter to 1 millimeter a day. We are probably a week away from this covering over completely, where the patient won't even realize that we did anything. Maxillary posterior, again, another root canal treated tooth. This is an interesting case. This is my last case, Lauren. We'll stop after this. But after removing the tooth, look at that defect. That is the Schneiderian membrane of the sinus floor. I did not incise it, I did not cut it, I did not damage it, but we can clearly see the Schneiderian membrane. This is a huge defect, a huge, huge defect. So here I'm going to use a combination of material. I'm going to use my osteogen plug, and I'm going to kind of place it gently into that sinus area, kind of lifting that Schneiderian membrane up. I'm then going to take my allograft material from GoldenDent, and I'm going to fill the rest of that defect with allograft material. Now, doctors, I'm going to finish up in a moment to answer your questions. When we're using an allograft material, what do we have to do? We must have a membrane to protect invagination of epithelium. Doctors, we can grow a facial plate of bone 100% of the time, as long as we eliminated the infected area, eliminated granulation, eliminated purple blood, and protected that allograft from invagination of epithelium using a high quality membrane like the one we can purchase through GoldenDent to protect it from invagination of epithelium. So here's my graft, my membrane, which is passively placed. There's no magic here. Passively placing it onto the palatal and suturing it closed, being aware of the band of attached gingiva on the facial aspect of this tooth. 1 week post-op, we're starting to get formation of a ridge, and I will allow this probably allow this, because this was such a big defect, to heal for probably closer to 6 months. I'll periodically see the patient, say after 3 months, maybe 4 or 5 months. I would do a CBCT in my office and determine the integration pattern. Remember how it's going to heal from the apex towards the crest. So Lauren, we're about 8 minutes before the hour, and I know you'd like me to stop about this time, and I'd be happy to answer any questions that we may have.
I'm going to turn it over to Kurt for a couple of minutes, because I know he would like to make a special offer and talk about some of the educational opportunities as well. Just some brief housekeeping to remind everyone: the webinar is recorded, so if you came in late and didn't see all of it, no worries. That will get sent out in the next couple of days. And if you're on at this point, it means you're probably eligible for the continuing education credits. Those are handled automatically. There's no quiz or test or anything you need to do. You just got to, when the webinar is done, you just sign out. GoldenDent sends those out automatically. That can take up to a couple of weeks, just because of the number of people. We had over 1,100 people registered. So I'm going to flip it over to Kurt for a few minutes, and he's going to talk about their special offers, and then we'll open it up to the Q&A.
All right, Lauren, I appreciate it. Hello, everybody. My name is Kurt Lawler. I am here in Detroit, Michigan, also with Dr. Kosinski. We're a third generational dental family, like I said, here based in Detroit, Michigan. We have historically focused since 2007 with the product-based business and the educational aspect that started with the physics forceps on designing and manufacturing sort of niche or unique clinical products that are effective and unconventional. So the code that you'll see here on your screen, I kept it kind of simple this evening, and I guess they say 1111 means good luck. So today's May 11th. Kept the code simple. It's 1111. So 1111 discounts 1111. And so the website is golden-dent.com for our product-based aspect of what we do here. If you're not already familiar with GoldenDent, And then Amplified Dental is our educational component of our business here. So we do these for just as a thank you for joining this evening. If there's anything that sparked your interest, we allow a discount code of 11.11% to be used for 24 hours. So that's good through tomorrow, which is May 12th. I'm gonna fly through this here pretty quickly, so just bear with me and then we'll get to the questions. Like I said, this is the physics forceps. It's been 14 years now, which is hard to believe, but this is what started what we do with the product-based aspect of our dental business. And so the physics forceps is 4 instruments. There's 1 lower universal and 3 uppers. If you're not already familiar with the product or haven't tried them, this is definitely the set that is the set to start with. Make sure you like the concept and technique. They're the easiest to use. If you want to use an elevator, I think the one that Dr. Kosinski showed this evening was in the bottom right there. It's sort of like a bayonet type shaped instrument, but you can obviously use a luxator or whatever elevator that is your preference of choice. Remember, the physics forceps really is not a forcep, it is an elevator itself. So I'm not going to say that this is always a necessary step, but obviously it will make the procedure easier if you do elevate a little bit in advance. We didn't show this, but this is a set of 2 instruments. They have actually been out for a while now, but these are going to allow you to get further back into the mouth for what we call hard to reach second molars and erupted thirds. However, I don't really suggest just jumping right into these. The technique on them is I'm not going to say it's hard, but I mean, it's more technique sensitive than obviously the ones we just showed with the green bumper, where it's a simple up or down type movement with your wrist. These go straight into the mouth and get around the cheek restriction, but you have to turn your wrist sort of like in slow motion, like you're turning a round doorknob. So if you don't have them and are looking to try them during our trial period, I would probably start with the other 4 that I just showed. This is a great burr kit. So if you are doing grafting or prepping a site for placement of a plug or a bone graft, as was demonstrated this evening, you obviously want to curette the socket very well, create a bleeding bed for the plug to be inserted. But if you can't, I guess, manually curette the socket into some of the crevices, those tissue and degranulation burrs are quite nice that come in this kit. There's also some bone leveling burrs and a good cutting and a shaping burr. This is something we made that's nice to have with your grafting kits or with your grafting instruments or your grafting procedures. This is the graft kit that was referred to this evening. Dr. Kosinski helped us put this together. It's inexpensive, it's nice looking, you can keep everything together. It's a nice kit to get out for any of your procedures for, I think it's under 500 bucks. Maybe even a little bit cheaper with the discount. We also have the more advanced instruments. So if you're looking for something that's more special, I don't have time to go through each one of these this evening, but a lot of them have a cutter for the suture. These aren't really your conventional hemosets. They really are have some nice unique features, including the no joints or the snagless aspect, where I know it can be annoying if the suture snags the needle holder. That's one great benefit that this product has, is there's no joints. We call them our snagless needle holders. And then the scissors and various different things. Like I said, there's all kinds of videos on our website, but we do have more advanced instruments than just the basic kit I just showed, if that's something you're used to. So our bone graft, so we have our particulate and the putty. There's really, not much difference. It's just the shape and the manner and the cutting comes in. These are going to be, if you're using a different Allograft brand, I encourage you to take a look at our GoldenDent brand. We always have the product in stock, and we think our pricing's fair. And that's the typical sizes you're familiar with, the 0.25 and the 0.5 and the various sizes. We showed the plugs in pretty good detail this evening. This is a great product. It was already demonstrated. I won't really spend any more time on this evening. The plugs are available. We have them in stock. There's actually 3 sizes now. There's a large, a slim, and there's actually now an extra large size for like those larger voids that were shown in the last case. There's actually extra large size plug now if you're not familiar with it. Dr. Kosinski's choice is the Epiguide. Again, I won't really go through this, but we do have 2 long-lasting resorbable membranes. I would recommend the Epiguide. The only issue is it's a little bit large. It's 18 by 30, so a lot of doctors will pre-cut that membrane prior to use or placement. We have our PJ sutures. These are the PJ sutures that Dr. Kosinski likes and recommends. And then we also have the black silk sutures, which is not Dr. Kosinski's choice, but we do have those available. If that's your preference, we do have the black silk available also. Pre-procedural rinse. This is going to be something that, you know, with today's day and age, we're getting a lot of really positive feedback on this. To be honest, this is the only really one that's done a test on actual saliva in the mouth. So all the other ones and some claims that are out there from some other pre-procedural rinses, this is the best one. And it's been proven. There's all kinds of documented studies on our website to read if you really want to get into the technical data. But this is the one that really does work. I'll why have your attention this evening? I know we get a lot of regular customers that join. We just added a bunch of more like discount surgical instruments. People are always asking us, you know, I'm on your website, you have probes and scalpels and different, you know, all kinds of different various dental instruments. So we went ahead and added those. They're kind of buried on our website. It's not our main focus, but I wanted to show you where they're at there. If you haven't been to our site in a while, take a look. I mean, these things are really inexpensive, and we have probes for, you know, $7, mirror handles $5, and et cetera. You can see the pricing on here. It's really inexpensive instruments, but it's the same quality you'd expect from our company. Last thing, I'm going to mention our CE real quick. So this is on Amplify Dental. We're finally getting back into doing live patient extractions and grafting and immediate dentures this fall. We have programs September through December. We've taken about 1.5 years off just due to COVID, and our plan now is to get back. This is our first one, September 17th through 18th. This is just the clinic floor here. I'm just going to go blaze through this, but this is a true hands-on course. So you do the procedures. You don't need a special Michigan license. If, you know, when the border opens back up, we always have a lot of doctors join us from Canada. It's a true hands-on course. So we see, you know, typically 80 to 100 patients, do a lot of extractions, and it's a great experience to do some of the types of cases that were demonstrated this evening on actual live patients. I want to mention this because it's coming up June 11th. It's only about a month away or so. Well, I guess it is a month away exactly. We have our Endo for the GP course. If you want to take a look at that, it's this is with Dr. Arnazarian. He's doing our Endo for GP program. I think we have a few seats left still for June 11th. We try to keep the class size smaller. It's a one-day program. I think we'll have probably around 10 to 12 doctors. That's at our office here in Detroit. So you'll see here's kind of the program. Everything's hands-on and on model work. We're kind of doing these types of programs until we can get back into the live patient aspect. I'll blaze through this. Is totally off topic, so I'm gonna blaze through this quickly, but related to our endo course, if you haven't been on a webinar in a while with us, we did launch a whole endo line with comparable pro taper type files and all of the aspects that go along with the endo aspects of our course. And this is a really, really great looking endo motor. Again, totally off subject from extractions and grafting this evening, but I wanted to mention that this is one that an endodontist named Yoshi Teruyuchi just kind of designed here. It's gold and black. It's a really nice looking endo motor that's priced fairly. I just wanted to make you aware of that. Why have your attention? And I will leave it at that and turn it back to Lauren and Dr. Kosinski for the question and answer session. And like I said, I went through that quickly. If you have any questions on the webinar this evening that we don't cover this evening, obviously give us a call in the office tomorrow. We're more than happy to help you out. Thank you.
Thank you, Kurt. Tim, you ready?
I am always ready for you, Lauren.
And, you know, for those of you who came on a little bit late, one of the things I mentioned, and I'll repeat it quickly here, is that there are way more questions than we have time to get to, even though we're going to go through as many as we can in the next 25 minutes or so. So I do apologize ahead of time, but when we have 1,100 plus people registered, we just can't get to them all. I've been looking through them. I'm trying to combine some of them, and we're going to get to as many as we can. Some of the stuff I guess maybe you hadn't talked specifically on this webinar. When you use an osteogen product, like the strip, for example, is there a reason you would use that versus, say, particulate graft and membrane combined?
Yeah, that's a great question. I think that the innovations are they're trying to make it convenient for us. So a strip is the same material. I used to take the plug and I would cut it and I would smash it and make my own strip. My rule of thumb for those who are listening today is I like the osteogen material specifically for sockets where all walls are intact. That's the ideal placement for it. Immediate implant placement or just grafting to hold it in sight. We're doing a lot of research on it. I will use it up to a 4 millimeter defect on the facial, 4 millimeters of vertical bone loss on the facial. Anything more than that, I personally prefer to use an allograft material and a membrane. And remember, I make my reflection, Lauren, beyond the defect so that that membrane is passively placed at least 2 millimeters beyond the defect. I sometimes will use the osteogen material and place a strip on the facial aspect to try to plump the site up. And sometimes I'll use a membrane over the osteogen material also, depending on how big the defect is. Sometimes we can layer it. So every situation is a little different, but I think the ideal situation for the osteogen plug is when you have a socket with all walls intact. That's where it's going to be most predictable.
What about, is there a situation where you would use a resorbable membrane, a resorbable like collagen membrane versus Epiguide? And are there any contraindications for one versus the other?
That's another great question, Lauren. I think that the important part is, there's a lot of I only use a resorbable membrane. I don't even have a non-resorbable membrane in the practice anymore. Those days have passed because the resorbable membranes are such high quality today. They could be pericardium, they can be different materials. But the basic understanding is that the material has to remain intact for at least 6 weeks. Most of the collagen membranes, the high quality ones out there, are lasting 3 to 4 months. I just need it to last for 6 weeks or so to allow that epithelium to grow over the top of it. So when your sales rep comes in and says, "Oh, don't use that product, mine's cheaper," the question that I want doctors to ask is, how long does it last? And if they don't know the answer to that, then I wouldn't use it. True collagen plug, there's different materials, but some of them last days and it turns to snot. That's not graft. We have some collagen plugs that we'll use for clotting that last 3 weeks. That's not a graft. The material has to be there for at least 6 weeks. And so just be aware of that. Oftentimes I'll use like a collagen plug to protect a site when we have a smoker, something like that, where I know that the site's going to heal in a week or so, and the patient's going to continue to smoke. I just want to protect the sites as much as possible.
Okay. If you're seeing some patient discomfort with use of the plug, is that typically because you didn't have proper bleeding? And how do you get that bleeding? Is that the likely issue when the patient has discomfort?
And that's an interesting question, because I do get emails on that, and I think that the importance is that we atraumatically remove the tooth as much as possible, meaning we're not traumatizing the bone, we're not grinding, we're not taking a high-speed burr and damaging the bone. Number two, you have to remove the granulation. And I know as general dentists, we have a tendency to be a little lazy sometimes, including myself, but you need sharp instruments. You need a grafting kit with sharp instruments, high quality materials. Red blood is good, purple blood is bad. If you don't have a bleeding site, you have to create it. And I'll take a round burr and simply start making little penetrations to get the graft to the physiologic response. You have to have blood there. Otherwise, you have a dry socket and it's not going to heal properly.
Okay. In the physics forceps, the universal, is it going to work for second molars, or are you typically suggesting that they get a molar one for really posterior teeth?
Yeah, I'll be very honest, and Kurt knows my feeling. I think that it's all about access, and it is a tool, Lauren. It's not an end all for everything. A second molar, you could probably luxate that one out, right? By elevating it distally if there's not a third molar there. As long as you have a purchase point and some semblance of a vestibule. Now, you don't always need to use the bumper guard, and that gives you a little more access. So again, it's a tool. I don't really care for them. Their molar. I'm being very honest with you. Sorry, Kurt. Their molar forcep, because I have a hard time using it. Other doctors may find it easy, but I like the 4 instruments that we have. That's what I use almost every day.
Okay. What about if the crown itself is fractured? Can you still use the physics forceps? And if someone wants to, maybe see the technique in a little more detail, are there like some YouTube videos or other types of videos out there that they can see?
Yeah, we have a ton of them. They can go to drkosinski.com, as I mentioned, or they can go to the GoldenDent YouTube channel. They're all online. Everything that we've done is on the cloud, and we share all our information to the entire profession. Absolutely.
Okay. How long does osteogen take to convert to bone?
So as I mentioned, we can look at it objectively, radiographically, and you're going to see a turnover. Normally I would wait 3 to 4 months, depending on the size of the defect or the socket. Like a bicuspid, probably 3 months, maybe a big molar, 4 months. But again, I'll bring the patient back and take a radiograph, and you'll see how it's changing over. That radiolucency will become more radioopaque, especially at the apical portion where it starts to heal over.
Okay. Let's see here. When you're placing the osteogen plug, do you need to decorticate the socket walls?
You want bleeding. Okay. Now, I don't always decorticate it. You want to eliminate the granulation tissue, and you want a bleeding site. If there's no bleeding, then I will decorticate, but I do not do that routinely.
Okay. Let's see, this is kind of a longer question. Sometimes I have a socket that is bigger than the osteogen plug, and I know it will condense short of the existing epithelium. Is there any benefit in using a sandwich combo allograft and osteogen plug sheet for large grafts that are bigger than the osteogen plug?
Yeah, that's what I demonstrated in that one case. But you can layer several plugs, and now they have a giant size one, and they're all the same price. The small. The small plug, the large plug, and now this jumbo plug are all the same. Are all the same price as I recall. You can ask Kurt there if that's the case, but I think they're all the same price. So there's different sizes. You can mold it together. It's all the same material. It's just different shapes.
Okay. Let's say you put the graft in, the site's ready in 4 to 6 months, but then the patient wants to delay. Is there a risk of further resorption, or, what's the longest after, I guess, the graft is ready that you would go ahead and place an implant?
Yeah, well, as a periodontist, that it takes about a year for bone to mature completely. So everybody wants to know how fast you can get it done, not how, if it takes longer. So, if we wait up to a year, I have no problem. After that, I'll tell the patient that because it's not being used, remember, because it's alveolar bone, it's going to resorb in the absence of force. It could start to resorb over a period of time. So, after a year is fine.
Okay. Let's see. In your example, comparing the osteogen plug and conventional grafting, isn't it true that the osteogen plug cannot be used in cases where there's a buccal defect?
Okay, we're just currently doing a lot of research on that right now, and maybe Lauren, I know you like to see the new cases. We got about halfway through the program, so maybe we'll demonstrate where we used it to build a facial wall. I'm not suggesting it at this program here. I would rather that the doctors use an allograft and a high quality membrane and know that we can build a facial wall. But we are working on osteogen and the sheets and determining if we are indeed getting the results that we want. I just want to be very honest with everybody. If we're going to do this, I want it predictable for everybody.
Okay. Any issues with dry sockets and the plugs, specifically on the mandible?
No.
Okay.
I just don't see it.
Can you place the plug material around implants if there's space, say, between the implant threads, if there's some exposure there?
All right. That's a whole nother topic, treating of the failing ailing implant. I think that it's very, very difficult to get height using any graft material. A wall, as long as there is a viable bone on either side of the defect, then we treat it just like any other facial defect, and the answer to that is yes. In those situations, I would either use an allograft or the osteogen, but I would place a membrane on it to protect it. Obviously, it's better to place the implant ideally so that you don't have that defect, but treating a failing ailing implant is challenging with any material.
Okay. Is a perio dressing recommended for coverage of large defects, especially in patients that are smokers?
Never. I don't use a perio dressing at all. As I said, if you're going to place an immediate implant in a smoker and you have a socket that's exposed, let's say you can see the top of the implant, then take either take the osteogen plug and cut like a manhole cover, or I don't care if you use a collagen material, and just shove it into that socket over the top of the implant and then suture over the top of it, just to protect it. It's only for while the epithelium is growing over the top, and that's going to happen in a week to 10 days. So you just need to protect it for that short amount of time.
Okay. When using allograft over the plug, do you cover with resorbable or non-resorbable membrane?
I use a resorbable membrane. Yes. Allograft, always a membrane, always.
Okay. What if you're just having trouble getting bleeding in that socket, especially if like an older patient, for example? Is there a way to, garner more heme to help the graft and the healing?
Again, whatever you have to do, scrape, drill, you have to have bleeding for it to work. Yeah.
Okay. Okay. At the time of extraction, there is a high mucosal label attachment with lack of attached gingiva. Do you do anything at the time of extraction, and if so, what?
So, well, it depends. Again, I mentioned that I don't need primary closure. And I have no problem leaving the membrane or the graft exposed, because I know epithelium is going to grow 0.5 millimeter to 1 millimeter a day. It's going to grow over the top of it. If you do get closure and you don't have a band of attached gingiva, then that's a secondary procedure that I would do following placement of the implant, or on uncovering, where I'll put a healing abutment after the implant has already integrated. But you must have attached gingiva on the facial aspect of your implant.
Right. Okay. In the last case, did you use the osteogen plug only because the sinus membrane was exposed, or would you routinely use the combination of the plug and allograft and membrane for 3-well defects?
Well, I could have used just allograft in that area, but I just wanted to demonstrate that the consistency of the osteogen plug is such that it gives me a lot of control. It's not a particulate, and I was able to kind of trying to push that Schneiderian membrane to give me a little bit more vertical height in that area, and that's why I kind of sandwiched it.
Okay. If there's like an active infection, are there situations where you would hold off on placing the graft?
Okay, active infection, again, curette. I don't have a problem, Lauren, placing a graft in a site where there's purulence. I like to use the analogy of a hangnail. If you've ever had a hangnail on your toe, you're miserable. You can't stand it. It hurts so bad. You soak your foot, you clip it, 5 minutes later, you forget that you even had it. The body is an amazing thing. Once the source of the infection is gone, as long as the patient has reasonable health, it's going to integrate. But I never place an implant in an infected, I never place an implant in an infected site. That's something I will not do. So if there's purulence in the site, I will not place the implant. I'll graft it, let it heal, and then put the implant in later. Great question.
Okay. How do you remove and graft granulation tissue that sits near or on top of the inferior alveolar nerve?
You're setting me up for a joke. Very carefully. Sorry. You have to be careful. You're using sharp instruments. And if you perforate, it's not the end of the world. The Schneiderian membrane grows very quickly. If you did perforate, then you would place a resorbable membrane that would become your new floor, so to speak, and then graft carefully in that area.
Okay. Okay, I started thinking outside the box here. If you have a buccal defect, is it possible to use an osteogen plug as a membrane to protect the particular graft in the socket? Epigрафts are sometimes difficult and they scoot away. And can you use osteogen as a membrane?
I'm going to say I don't suggest that. Yes, you could, but I would not suggest that. You want something that's going to last a good amount of time. And again, we're just starting to document those type of situations. Lauren, maybe we'll do the next webinar on that. I don't want to mislead people because that's how we think. We want a panacea. It's just a product, and I probably don't like that idea for a defect greater than 4 millimeters on the facial aspect. Can I leave it at that? Yeah.
Yeah, sure. Any contraindications for the graft materials that we've discussed for people on oral biphosphonates?
Well, not so much the graft material, but it's the extraction. Bisphosphonates. The way it works is it's coating the cortical plate, and the physiologically osteoclasts attack, eat, and die. And without that osteoclastic activity, they cannot signal the osteoblast to lay down new bone. So people on bisphosphonates long term, it's more of a surgical concern rather than a grafting concern.
Okay. Do you rinse after your curette? And if so, what do you use to rinse the site?
Just a sterile saline. Yeah, never chlorhexidine. Although I recently I was always trained never use chlorhexidine in a socket site because it affects the fibroblastic activity, blah blah blah. But now I'm seeing in the literature more that the periodontists in the periodontal literature that they are rinsing with chlorhexidine. So I don't use chlorhexidine in a socket. I have the patient rinse before, obviously, or with the other rinse that we recommended prior to. But I don't irrigate other than with sterile saline in a socket site.
Okay. Have you ever tried using an osteogen plug on a facial defect to widen a ridge or cover any implant that may be exposed outside of a ridge?
Yeah, that's tough to do. I don't suggest that.
Okay.
It's unpredictable. I don't know if it's going to work or not.
Okay. When should you use particulate grafts over the osteogen plug? Horizontal ridge augmentation, sinus lifts, any other situations?
Normally I would use one or the other. And again, if I have a facial defect, I'll use Allograft with a resorbable membrane. Sinus tenting, I'll use either or. I get equal results, I think, although it's very difficult for me to do the histology in a sinus lift. I'm not going back and coring that site. So it's basically me determining it radiographically, the results that I get. And so I think we get equal results. Man, it's just replaced. It's just a matrix to be replaced by natural bone.
Okay. Can the membranes be cut and reused later? Can they be sterilized?
I'm not sure I understand that question, but I would say that if you have a sheet of membrane, you can cut it off site into several pieces to be used individually, but in the operatory, yeah, they're one-time use. Yeah.
Yeah. Can you place an immediate implant through an osteogen plug?
Absolutely. Do it all the time. Yes.
Okay.
It almost acts like caulking. The implant will push the graft onto the walls of the socket.
Okay. Should the graft material be moistened before placement?
No. Blood will moisten it.
Okay. Can you use an osteogen strip as a membrane on a facial defect when using an osteogen plug in a 3-well socket? I think we had a question similar to that before.
Yeah, I don't recommend it. If it's greater than 4 millimeters, we're just doing that research now.
Okay. Can you use a PRP membrane instead of resorbable membranes?
All the time, absolutely.
Okay. Can osteogen sheets be used as a membrane successfully?
I don't suggest that for a defect. If it's greater than 4 millimeters, I know I'm repeating myself, but we're just going through that research now.
Okay. When do you place only osteogen plug, then suture it, and when you place osteogen plug, then allograft, or on top of it, and membrane and suture it? What are the criteria to choose one way versus the other?
Normally, I mean, the case that I showed was a huge defect. It was huge, right? It was tremendous. But normally I would use one or the other, Lauren. Allograft and membrane or osteogen by itself.
Got it. Okay. Well, I want to give you a couple of minutes to wrap things up. And as I said, we tried to get through as many questions as we could. But we do want to be respectful of your valuable time, Tim, and everyone else's time as well. So anything you'd like to say before we put a cap on it?
Well, yeah, as you mentioned at the beginning of the program, we really do work hard in trying to demonstrate new cases, and kind of different cases, but things that the audience you're seeing in your practice and going by the questions, I think it's valuable, and so I truly appreciate your efforts and what you do to improve the profession. I think that's very honorable of you, and I truly appreciate it. And I enjoy our time together. I think I see you more than I talk to you more than I talk to my wife sometimes. But I hope everybody's
not sure how to take that, but okay.
Well, she's not here, so we will hopefully everybody stay safe and healthy. As things open up, I know we're very, very busy, here in Detroit. But God bless and stay safe and stay healthy, and we'll see you next time, Lauren.
Thank you. And we're seeing a number of people commenting what a great seminar it was, and thanks. And we appreciate those kind comments. It certainly makes it all worthwhile. I wanted to thank Dr. Kosinski for his time and expertise. Any of you that had not heard him previously know why I've been raving about him, that you just see some great cases, and he's really very plain spoken and explaining things in terms that everyone can understand, and that's why we keep bringing them back on a regular basis. As I also mentioned at the beginning, we cannot do these webinars without sponsorship. It takes a lot of time and energy and unfortunately money to put these presentations together. Kudos to GoldenDent for their ongoing commitment to dental education and supporting these webinars. As they mentioned, as you can see on the screen for the last half hour or so, you can take advantage of that promo code and say that's a lot. Actually, normally their savings are less than 10%, so 11.11% is pretty significant. Take advantage of that promo code. You can call them up. You can go to the website goldendent.com or Amplify Dental for the training as well. So thanks to Kurt and GoldenDent for their sponsorship. As I'd mentioned a couple times, and for those of you who may have come a little bit late, the webinar is recorded. It will be sent out to all of you within a couple of days. The CE form is when you log out. There's nothing you need to do. No quiz, no test, no verification. GoldenDent handles that automatically. that can take a couple of weeks because we did have well over 1,000 people registered for this evening. We thank all of you for your time. We know it's valuable. We hope that you find these webinars entertaining and valuable. And I think that's the case because we're averaging over 1,000 each time. But all of you are on the invitation list for future webinars, and we usually do them with GoldenDent about one a month, give or take. So watch your inbox over the next couple of weeks for the next set of invitations. Thank you all for joining us. Thanks, Dr. Kosinski. Thanks, Kurt from GoldenDent, and we look forward to seeing everyone on future webinars. Good night, everyone.
Good night.